is Alice Hamrick-Martinez. I'm a licensed professional counselor with Kellen Mental Health. We are a private practice located in the Alpharetta, Georgia area, and we take a holistic approach to wellness. We have several clinicians that have various niches, all the way from trauma work and EMDR to perinatal mental health services for women. And then for myself, I specialize in OCD and anxiety disorders and support clients coming in looking for some exposure and response prevention therapy, and I use ACT as well. OCD is Obsessive-Compulsive Disorder, and it's a condition that focuses a lot around certainty. OCD really seeks to want to understand certainty, and it kind of perpetuates this cycle of obsessions, feeling anxious, discomfort, and then an individual will engage in some kind of compensatory behavior, or what we call compulsions. They get a little bit of relief, but then the obsessions come right back. The obsessions, which you can hear that in the name, Obsessive-Compulsive Disorder, the obsession is such a key part of having OCD, and you can feel from a person how it's very ego-dystonic, meaning they don't want to have these intrusive thoughts, they don't want to experience these obsessions. You can feel in therapy how much they're trying to escape this experience. And so through the OCD loop, the way that they're trying to attempt the escapism is through these compulsions, but the compulsions actually just feed the cycle, and kind of you might hear people say, you know, I'm just looping, and it is true. You just kind of go round and round, and you feel very stuck. With generalized anxiety, that's a little different because it's a little more general. The anxiety is a bit more fluid. The anxiety is gonna rest in areas that are more everyday type challenges, like it could be finances, interpersonal relationship difficulties. It could also be, I'm worried about school performance or my grades, or something like that. And what generalized anxiety, what you typically don't see is that intensity that I was talking about before with the obsessions and the intrusive thoughts, where it's not as like ego-dystonic as we typically see with OCD. And you also don't see these very rigid rituals or compulsions like you do with OCD in comparison to generalized anxiety. The misconceptions is, do I have to, be a neat and orderly and clean person? The answer is no. That is not a prerequisite to having OCD. You can be a quite messy person and still have very severe OCD. Sometimes there are compulsions that are around, like needing something to look a certain way, like you need symmetry somewhere, or you do want something to be clean and organized. It can kind of rest in that place from a compulsion perspective, but you don't have to have that. There are many subtypes of OCD. Another thing that people don't oftentimes realize is how internal OCD can be. Meaning compulsions can be external. You can see someone maybe engaging in hand washing, you can see someone checking something, but there are also compulsions that are more internal, where I might be replaying a conversation over and over again after I've been having these intrusive thoughts that I was at a party and I did something stupid, and so now I'm replaying over and over again, what did I do? How did that conversation go? Maybe I'm checking, mentally reviewing, what actually happened. And you can't see any of those things. It's all very much internal for the person. So that's something that people don't oftentimes realize, is how internal the OCD experience can also be. And some of the subtypes or ways that OCD pops up for some of my clients is surprising. One of which is it's centered around this theme of like perfectionism, needing for something to feel like just right. And so I may have a client come in and they're like, I cannot make a decision when I go to a restaurant. I'm trying to pick a menu item and I get so stuck that I just end up giving the menu to my husband and I just have him choose for me. And so what's happening is they're looking for a menu item that feels just right. Whether it's just right from a nutritional perspective, whether it's just right to meet some kind of craving, but they get stuck because they want that certainty of feeling like this is the exact right item on the menu that I should be getting. And so I will sometimes think in the room, I'm like, I wonder if they know this is their OCD. And so we call it out together. We kind of recognize that the reason you're feeling so stuck is because you're looking for that certainty. And so maybe an exposure would be, you only have 2 minutes, set a timer, you only have 2 minutes to pick a menu item when you go to a restaurant. And so that would be a way you're kind of engaging in the exposure, trying to limit the response of avoiding and having someone else just pick the menu item for you. So that one's really surprising to folks. Another one that's just surprising in general is pedophilia subtype OCD. And I say it's surprising in general because a lot of people don't know about this subtype. There is unfortunately a lot of shame and guilt around this subtype where individuals will go years and never get help for it because they're afraid to come in and talk about it. They're afraid to kind of expose those intrusive thoughts around pedophilia. And, you know, if you're working with a clinician that is not specialized in exposure and response prevention, they could easily kind of misdiagnose this or, you know, kind of view this through a lens that's incorrect. And so one thing we always look for is that kind of ego dystonic posture where someone comes in and it's very distressing to them. They don't like that they're having these thoughts around pedophilia. They're very emotional about it. There's just a lot of dysregulation over these obsessions and intrusive thoughts. And it's such a hard one because like I said, there's so much guilt and shame, but OCD uses guilt and shame to keep you stuck. One of the biggest things is helping a loved one kind of decipher, am I supporting the person or am I accommodating the OCD? And what this might look like is, like, let's say my child comes and they're talking about riding the bus. You know, the first day of school is approaching. It's another life transition going, you know, switching grades, switching schools. And so sometimes this can create some level of anxiety for a person. And so I notice my kiddo, they're talking about school and they're like, you know, I've been worrying a lot about the bus not coming on time. And I'm worried that, you know, if the bus isn't here on time, then I'm late for my first day. And then what if everyone else gets their seat in homeroom and I have to pick the last one? And like around and around, their mind is kind of spiraling. And a very well-intentioned statement, but not effective, might be, you know, it's going to be fine, Sarah. You know, you're going to get to school on time. The bus is going to be here. You're going to have a great day. It's going to be great. Very well-intentioned, but not effective when you have OCD, because what you just did was you compulsed with your child. And so what the intrusive thoughts and the obsessions was around school, being late, feeling embarrassed, coming into class, and, you know, everyone's got their seat but you. And so you're feeling anxious, feeling discomfort. And so what's the compulsion? You're assurance seeking. You're asking your parent, am I going to be okay? Is this going to go, is it going to go well? And so the fact is, maybe not. The bus could be late. So we want to keep the door cracked open for the possibility that, yeah, these things could technically happen and they also could not. And so instead of compulsing with them, a healthier statement might be to say, you know, I hear that your OCD is really wanting some certainty over how the first day of school is going to go and when your bus is going to be here. But I know that you can get through the first day of school without that certainty. And so what you're doing there is you're kind of validating, you're calling out the OCD, you're saying, hey, you know, I think your OCD is really looking for certainty here. And you're also giving some installation of hope that I believe you can do this without needing that certainty. And that's really kind of the goal in therapy, is to bolster someone's confidence in their ability to handle life without certainty and really kind of surrendering to the unknown. ERP stands for Exposure and Response Prevention. It's kind of broken down into these two parts. We have the exposure part, which is literally facing your fear, the obsession, the intrusive thoughts, the anxiety. I kind of look at it as like I'm working towards clients getting closer and closer and closer to their fear, their OCD, kind of obsessive cycle, the cyclical nature of OCD. I want people to start getting as close to that as we can, and we do that through the exposure. And then there's another part of the response prevention, and we want to prevent people from responding to the obsessions, the intrusive thoughts, and the anxieties. We no longer want them to lean on those compulsions. And so that's kind of the dualistic approach. We're looking at the exposures, and we're also looking at, okay, how can we prevent the responses? And what that does for the brain is, if you're asking someone to engage in an exposure and limit the compulsions or not engage in any of the compulsions, you're showing the brain that I can lean into this discomfort, I can feel this anxiety, and eventually that anxiety is going to climb back down, and I didn't have to engage in a safety behavior to help myself get through this moment. And over time, you're teaching the brain that there's a new way of operating around the uncertainty, around these obsessions that I'm resting in, a new way of dealing with intrusive thoughts. And so there's definitely a neural rewiring process that happens as we engage in the exposure and response prevention work. What ERP looks like in the therapy room. So for me personally, I start out with encouraging the client to kind of get to know their OCD. I want to understand their OCD. I want to understand how the obsessions, the intrusive thoughts, the compulsions are manifesting in their life. And so if we can name it, we can tame it. So I want a person to get really good at kind of calling out the OCD. And being able to say, you know what, nope, this is my OCD, I don't have to respond to it. And so that's kind of the first thing I do. And then we kind of get into the exposure work and the response prevention part. And so I'll create like a hierarchical scale. And so what I tell clients as well is that it's going to feel a little bit worse before it gets better, because when I make an exposure scale, I'm going to be asking them to, again, get closer to their obsessions, get closer to those intrusive thoughts, and not be, feverishly trying to escape them, but we're going to be, facing them. And that's very dysregulating. And so I always preface that. And then I also highlight to clients that we don't ask you to just engage in the obsession or the fear or the intrusive thought that is the most dysregulating. We slice it really thin. And so an example of this might be, like I worked with a woman that had contamination subtype OCD, and they had a difficult time doing the dishes. And so there were obsessions around getting sick. If I am cleaning these dishes, particles are getting into the air, I'm breathing in this air, and then I could get sick. So that was the core fear, the obsession, causing a lot of anxiety and discomfort. And then the compulsions were they would leave a window open when they would do the dishes, they would wear gloves, keep their hair up, do all of these safety behaviors to try to minimize or eliminate the risk that they could get sick. So an exposure would not have been like, hey, just go home and put your hair down, take your gloves off, leave the window closed, just wash the dishes. That would not be a helpful thing for anyone to advise. So what we say is, let's back it up and let's try some imaginal exposures. So let's just imagine maybe for 10 minutes, you do the dishes without the gloves on, with the hair down, with the window closed, but I'm not actually asking them to do it. I just want their mind to posture itself to consider, what would that be like? And sit with that for 10 minutes. Anxiety is going to rise, but also we're not going to be engaging in those compensatory behaviors like, they could be replaying in their mind all the times that they did do the dishes with gloves on, hair up, window closed. We're going to resist that. And I say lean into the discomfort, feel all the anxiety that comes up as you're imagining doing the dishes without the safety behaviors. And so once we kind of get through that and we're building up some tolerance for that uncertainty and these lower level exposures, then we kind of move up the scale and do something that's going to create a little bit more anxiety and discomfort. So, I said, okay, I want you to try, we even, I had her like just look at the dishes in the sink for 10 minutes. Even that was kind of difficult. So we even, went there, and then I had her, take one glove off, you keep one glove on and do the dishes, until eventually the goal was to not use any safety behaviors and be able to get through the cleaning of the dishes. So it took a lot of time, and it's definitely non-linear, and it can be really tough, and it definitely gets worse before it gets better. But the goal is to help that person feel confident that they could do the dishes without needing the certainty of how particles in the air were going to impact them. One of the big ones I like to talk about is exercise. OCD and a lot of mental health conditions in general can be so dysregulating to the nervous system, and exercise helps to regulate the nervous system. It's great for brain health, and so that's one thing I'm always encouraging clients to engage in. It doesn't have to be intense exercise, like just move your body, go for a walk, do some light stretching, but anything in that realm I do believe is really impactful and important for just our mental well-being. Another one is like making sure that your basic life needs are met. Like, are we eating a balanced diet? What are we putting in our bodies? Let's consider what that looks like and how could we maybe improve and find some improvements there. Sleep is another big one. OCD specifically does tend to be more intense the more tired we are. So I am considering, how many hours of sleep are you getting? Is it enough? Do we need to, send a referral out for a sleep study? I'm really always curious about sleep and how could this be contributing to the OCD intensity. So that, and OCD can also feel really isolating, and so I'm always encouraging clients to stay connected with their family, friends, get out in the community, stay connected, because the isolation also can just intensify the experience of OCD. And it's already intense enough, and so if we can do some things and manage our environment a little differently to ease some of that intensity, that is something I'm always looking for. Just want to say thank you so much for joining me today. I hope you learned some interesting and important things about OCD, and if any of this stuff resonates with anyone, please know that there are a lot of clinicians out there who specialize in OCD treatment. And it's worth it to just go get an assessment, talk to someone. And for those who do have OCD and they know that they do, always remember OCD lies. It does not tell the truth, and we do not have to believe in every silly thing we think. And if you guys are interested in learning more about Kellen Mental Health, please go and check out our website. We have a lot of great resources listed. We have a lot of amazing clinicians that work at Kellen. So please stop by our website, check us out. We're happy to help if you're in need.